Trust is not just a philosophical or emotional concept. It's biological. It lives in the brain, it is processed through networks of the limbic system, and it directly influences our behaviors, perceptions, and even our health outcomes. When we think about trust, whether in another person, a system like public health, or in scientific information, it's critical to understand that we are talking about something that is physically instantiated in the nervous system. In the context of public health, trust is the difference between adherence and resistance, between cooperation and skepticism, and in many cases, between health and disease at the population level. From a neuroscience perspective, trust emerges primarily from activity in three brain regions: the amygdala, which processes fear and emotional salience; the prefrontal cortex, particularly ventromedial and dorsolateral regions, which are involved in decision-making and social reasoning; and the insula, which helps interpret internal signals and social emotions like empathy or disgust. Together, these regions form what we might think of as a trust circuit. When we are confronted with new information, say, a public health recommendation to wear a mask or get vaccinated, this circuit evaluates the source of the message, the consistency of the information, with our prior beliefs and the perceived intention behind the message. Interestingly, trust is more of a prediction than a reflection. The brain is essentially running a calculation. Do I predict that this individual or system will act in my best interest in the future? That prediction is shaped by past experiences, observed behaviors, social modeling, and emotional context. When people say, "I don't trust the system," they're often communicating that their predictive model based on previous breaches, conflicting messages, or perceived manipulation forecasts future harm or deception. And here's the key point. That model is neurobiologically reinforced every time that belief is confirmed by further inconsistency or ambiguity. Now let's dive deeper into the neurochemistry of trust. One of the main players here is oxytocin, often referred to as the bonding hormone. When we engage in positive social interactions, hugging a loved one, receiving support, or feeling heard, oxytocin is released. It lowers activation of the amygdala, thereby reducing fear and increases social bonding. But oxytocin doesn't just make us feel connected, it makes us more likely to believe others. Experiments show that administering oxytocin increases people's willingness to trust strangers in financial games. This has profound implications in public health. If people perceive scientists and health professionals as out, group, or distant elites, the oxytocin-mediated trust system doesn't engage. But when there's continuity, familiarity, and a sense of shared identity, that biological system kicks in and trust becomes possible. So how does this all tie back to restoring trust in public health? The first thing to acknowledge is that once trust is broken, it is neurobiologically harder to rebuild. This is due to a principle known as negativity bias. From an evolutionary perspective, the brain gives more weight to negative experiences than to positive ones. If a lion tries to eat you once, you're better off assuming all lions are dangerous. The same goes for systems of authority. If someone perceives that the public health system lied once, even if it didn't, it's much harder for the brain to shift that schema back to a trusting one. The amygdala literally tags that institution as threatening, and future interactions will be filtered through that lens of threat, not neutrality. But there's a solution. Because neuroplasticity is always in play, the brain is capable of rewriting associations. If we want to rebuild trust, especially in public health, the strategy has to be slow, consistent exposure to reliable, empathetic, and transparent communication. This aligns with what we know about exposure therapy in clinical psychology. When someone has a fear or distrust of something, gradual exposure in safe contexts rewires the threat circuits in the brain. Similarly, when public health agencies are transparent even when the message is "we don't know yet," and consistent in their actions, those same threat responses can diminish over time. This also ties into the concept of predictive coding in neuroscience. The brain is a prediction machine. It's constantly comparing incoming sensory data with internal models. When there's a mismatch, say, a health authority says one thing in May and the opposite in June, the brain flags that as a prediction error, especially if there's no clear explanation. If that happens often enough, the prediction model, the mental schema, labels that source as unreliable. To fix that, the brain needs repeated instances where the prediction and the outcome match. That means delivering on promises, communicating in stable patterns, and even acknowledging when previous information was incorrect, so long as the correction is done transparently and with reasoning. Trust is also tightly coupled with dopamine, the neurotransmitter associated with reward and motivation. When our brain gets something right, like predicting that a person or system will help us and then experiencing confirmation, it gets a little dopamine hit. That reinforces the model, but here's where it gets more nuanced. Dopamine doesn't just reinforce good experiences, it reinforces expectancy learning. That means if someone expects betrayal or confusion and receives it, that model is also reinforced. So for a population that feels underserved or misled by public health institutions, the continued presence of even small discrepancies or mixed messages can actually strengthen their distrust. Biologically, this is why, in efforts to improve science communication and restore public trust, the language we use is critical. The prefrontal cortex, which governs reasoning and long-term decision-making, is modulated by emotional inputs from the limbic system. If we communicate scientific information with empathy, clarity, and a sense of shared identity, we activate prefrontal engagement. But if we communicate with fear, shame, or superiority, we trigger defensive circuits, especially the anterior cingulate cortex, which processes social pain. That shuts down open-minded processing and increases resistance. One example from cognitive neuroscience that illustrates this well is the concept of reactance. When people feel that their autonomy is being threatened, even by something meant to help, they respond with resistance. This is observed in brain imaging studies as increased activity in areas like the insula and amygdala, signaling that the message is being received not as help, but as a threat to personal agency. In public health campaigns, mandates without proper explanation often trigger reactance. The solution isn't to eliminate mandates altogether, but to pair them with framing that supports autonomy. Language like "here's why this matters and how it protects you and your community" is more effective than "you must do this or else. Now let's connect this to real-world behavioral change." Studies show that when people perceive medical professionals as warm, relatable, and competent, their adherence to treatment increases significantly. That's not just about politeness, it's about the mirror neuron system, which is involved in empathy and imitation. When we see someone we relate to performing a behavior, our brain is more likely to mimic it. So, in public health, deploying trusted messengers, people who reflect the community they serve, can neurologically prime the population to adopt health behaviors. This is not anecdotal. It's measurable in terms of neural activation in the posterior superior temporal sulcus and premotor cortex regions tied to imitation and learning. Importantly, trust is not purely rational. Even the most data-literate individuals make decisions based on emotional and social cues. This is crucial because scientific institutions often assume that better data alone equals better understanding and adherence. But the brain doesn't work that way. It weighs emotional valence, how something feels more heavily than raw statistics. So we must pair our scientific messaging with narratives, with stories, and with human connection to activate both the emotional and analytical sides of the brain. Finally, I want to emphasize the plasticity of trust. Just as trust can be broken, it can be rebuilt because the brain is never static. But this requires understanding that trust is not a single event. It's a neural process over time. It requires repeated, predictable, emotionally congruent interactions. It requires allowing people to be skeptical without shaming them, because skepticism is the beginning of inquiry, and inquiry is the foundation of science itself. If we apply what we know from neuroscience, behavioral psychology, and systems biology, we can build a model of public health that is not just effective, but also human. A model that respects the brain's need for safety, autonomy, and understanding. A model that recognizes trust as a neurobiological imperative, not a luxury. And ultimately, that is how we begin to restore faith in science. Not by demanding belief, but by earning it, one connection at a time, one transparent action at a time, one brain at a time. Misinformation is not merely a social or technological problem. It is a neurobiological one. It has roots in how the human brain evolved to process information, assign meaning, and make decisions under uncertainty. And when we look at the issue through the lens of neuroscience, we begin to see why misinformation spreads so effectively and why it is often more persuasive than the truth, especially in times of fear or confusion. Understanding how the brain encodes, stores, and retrieves information is fundamental if we want to improve scientific literacy and rebuild trust in public health. The human brain is wired for survival, not necessarily for accuracy. At its core, the brain functions as a prediction machine. Every piece of new information is compared to a stored model or schema in our cortex, particularly within areas like the medial prefrontal cortex, which evaluates congruence with prior beliefs. If the new information fits with existing mental models, it is integrated quickly and often unconsciously. If it contradicts what we believe to be true, it triggers cognitive dissonance, a state of internal conflict that activates areas like the anterior cingulate cortex and the insula, which signal discomfort and uncertainty. This discomfort leads us to resist conflicting information unless we are in a highly regulated, cognitively flexible state, something that requires energy, time, and motivation. Most of the time, the brain takes a shortcut. It avoids dissonance and defaults to reinforcing prior beliefs. This is why misinformation that aligns with someone's worldview tends to stick more easily than corrective facts that challenge it. It's not a sign of ignorance or stubbornness. It's the default efficiency mode of a highly evolved nervous system. Now, let's consider the role of the amygdala, a key structure in the brain that assigns emotional salience to information. When misinformation is framed with emotionally charged language, fear, outrage, betrayal, it lights up the amygdala and enhances memory encoding through connections with the hippocampus. Emotional content has privileged access to memory systems. This is why urban legends, conspiracy theories, and dramatic misinformation are remembered and shared more readily than dry statistics or abstract public health guidelines. In short, the brain remembers what feels urgent, not necessarily what is accurate. Misinformation also takes advantage of what's called the illusory truth effect. This is a well-documented cognitive bias where repeated exposure to a false claim increases the likelihood that the brain will perceive it as true. This effect is mediated by the fluency of processing. The easier it is to recall or recognize a statement, the more likely the prefrontal cortex is to interpret it as valid. Even when we consciously know something is false, if we hear it repeatedly, it becomes fluent and familiar, and therefore more believable. This is why misinformation campaigns rely on repetition. The brain is not fooled because it is gullible, It is following evolutionary heuristics for processing information efficiently. Another important aspect is confirmation bias, which is deeply rooted in brain function. When we are presented with new evidence, the dorsolateral prefrontal cortex and the ventral striatum become involved in evaluating the reward of confirming versus disconfirming information. In functional MRI studies, the brain shows greater activation when people are presented with evidence that supports their existing beliefs. This is literally experienced as more rewarding. That means misinformation that confirms what someone already believes has a built-in neurological advantage. It delivers a dopamine-mediated reward, reinforcing the belief even if it is false. Now let's look at what happens when we try to correct misinformation. Many well-meaning science communicators assume that presenting facts will be enough to change minds. But neuroimaging data shows that when people are given corrective information, especially when it challenges identity, linked beliefs, the default mode network, a system associated with self-referential thinking activates defensively. This can result in backfire effects, where people not only reject the correction, but become more entrenched in their original beliefs. This is critical in public health, because attempts to dispel myths about vaccines, masking, or disease origin may inadvertently strengthen those myths if not done carefully. To counter this, we must apply principles from the neuroscience of persuasion and memory. For information to override existing beliefs, it must be processed in a safe cognitive context, one that reduces threat signals from the amygdala and allows engagement of the prefrontal cortex. This means delivering information through trusted messengers, using calm and non-threatening language, and providing context that preserves autonomy. If a correction feels like a social attack or moral judgment, it will not be accepted regardless of how accurate it is. Moreover, timing matters during states of heightened arousal, such as fear, uncertainty, or crisis. The brain becomes less capable of complex reasoning. The limbic system overrides the prefrontal cortex, reducing our capacity for nuanced thinking. This is known as cognitive narrowing, where attention is laser, focused on perceived threats, and information is processed in black and white terms. Misinformation thrives in these conditions because it provides clear, emotionally compelling answers. The truth, by contrast, is often complex and provisional qualities that don't feel satisfying when someone is in a reactive state. Social media amplifies this problem by hijacking the brain's reward system. Platforms are designed to trigger dopaminergic spikes, small hits of reward through likes, shares, and rapid novelty. Misinformation that is shocking, controversial, or emotionally intense is more likely to generate engagement. Each engagement acts like a micro-reinforcement, strengthening the memory trace of that misinformation in both the sender and the receiver. Even worse, these algorithms can create information silos, where people are only exposed to beliefs that confirm their worldview. The neural result is a strengthening of biased circuits and a weakening of cognitive flexibility. So how do we counteract this from a neurological perspective? First, we must understand that changing someone's mind is not just a cognitive task, it's an emotional and social one. For a person to update their beliefs, especially in response to misinformation, the brain must first feel psychologically safe. This means the amygdala is quiet, the prefrontal cortex is online, and there is minimal activation in regions associated with social pain or identity threat. Achieving this requires careful framing, empathy, and repetition. Second, we must teach people how their own brains work. Scientific literacy should include not just facts, but metacognition, the ability to reflect on how we form beliefs, how our memories are shaped, and how our biases operate. When people understand that all brains are prone to confirmation bias, memory distortions, and emotion-driven judgments, They become more open to evaluating information critically without feeling personally attacked. This is where neuroscience education becomes a powerful tool for public health. Third, we need to design public health messaging that leverages the same neural pathways as misinformation, but ethically and transparently. This means using narrative storytelling, emotionally resonant examples, and visually engaging formats. We should not dumb down science, but rather present it in a way that aligns with how the brain naturally processes and retains information. Visual cortex activation during compelling imagery, mirror neuron engagement during relatable stories, and dopaminergic reinforcement through affirming social values can all be harnessed to make truth more neurologically sticky. Fourth, we need prebunking, a concept derived from cognitive inoculation theory. Just like a vaccine trains the immune system to recognize and fight a virus before exposure, prebunking trains the brain to recognize and resist misinformation before encountering it. Research shows that exposing people to the techniques used in misinformation, like emotional manipulation, false experts, or cherry-picked data, activates the prefrontal cortex and improves critical thinking. When misinformation is later encountered, the brain is less likely to encode it as valid. And finally, we must acknowledge that belief systems are deeply tied to identity. Any attempt to counter misinformation must respect this reality. From a neural standpoint, attacking someone's beliefs can be interpreted as attacking the self. The posterior cingulate cortex and medial prefrontal cortex, both involved in self-referential processing, become highly active when beliefs are challenged. This leads to defensive processing unless the challenge is embedded in a relationship of trust and mutual respect. In summary, the neuroscience of misinformation reveals a simple but profound truth. The brain prioritizes emotion over logic, familiarity over accuracy, and social safety over abstract reasoning. If we want to counter misinformation in public health, we cannot rely on data alone. We must speak the brain's language, one of safety, emotion, repetition, and connection. And perhaps most importantly, we must recognize that every individual navigating this information landscape is not broken or irrational. They are simply human operating with a nervous system shaped by evolution to survive, not to process peer-reviewed literature. If we can meet people where they are, equip them with the tools to think about their own thinking, and foster environments of respect and clarity, then we stand a much greater chance of restoring not only truth but trust in each other and in science itself. Would you like me to continue with Keynote 3 in this same style? One of the most overlooked aspects of public health and scientific communication is the way in which information is delivered. It's not just the facts themselves that shape public perception and behavior. It's how those facts are framed, how they're repeated, and how they're emotionally interpreted by the brain. This is not just about semantics or marketing. It's about aligning with the architecture and function of the human nervous system. Transparent communication isn't a preference. It's a biological necessity for trust, clarity, and long-term adherence to health recommendations. Let's start with what actually happens in the brain when information is received. When someone hears a message, say, from a scientist, doctor, or health authority, that message is processed through a complex network of brain regions. Initially, it passes through the auditory cortex and language centers like Broca's and Wernicke's areas, which help parse meaning. But almost immediately, other systems come online, especially the amygdala, which evaluates the emotional salience of the message, and the prefrontal cortex, which considers its implications for decision-making. This means that how a message is perceived isn't determined only by the content, but also by tone, body language, consistency, and emotional context. A health expert who appears nervous, dismissive, or arrogant, even if they're technically accurate, activates threat related networks in the listener's brain. The amygdala interprets the speaker as a potential social or intellectual threat, and this perception can override the actual message content. The nervous system begins to shift into a defensive mode, activating the sympathetic branch of the autonomic nervous system, increasing cortisol, and making the brain more rigid and less open to updating its beliefs. Transparent communication, on the other hand, reduces this sense of threat. When someone openly acknowledges what is known, what is uncertain, and how conclusions were reached, it increases the activity of the ventromedial prefrontal cortex, which plays a role in social cognition and moral reasoning. This region helps us determine whether someone is being honest or deceptive, cooperative or manipulative. From a neurobiological standpoint, transparency enhances perceived reliability because it supports predictive accuracy. In other words, when someone communicates clearly and consistently, our brain becomes better at predicting their future behavior, and this reduces uncertainty, which in turn lowers anxiety. An important concept here is the role of mental models. When scientists or health professionals communicate transparently, they help the audience build accurate internal models of how something works. These models are formed in part by the hippocampus, which encodes memory and spatial reasoning, and are refined through prefrontal cortex activity, which allows us to simulate future scenarios. The better the model, the more someone can make decisions aligned with reality. But when communication is vague, contradictory, or overly technical, the brain struggles to build these models, leading to confusion, disengagement, or worse, misinterpretation. And here's the crux. When the brain can't make sense of something, it doesn't just wait patiently, it fills in the gaps. The default mode network responsible for narrative construction and meaning making kicks in and begins to supply interpretations that often rely on prior beliefs, emotional biases, or cultural narratives. This is how conspiracy theories or health myths take root. They offer complete, emotionally satisfying models in the absence of clear, transparent explanations. It's not that people want to believe misinformation. It's that their brains are biologically inclined to resolve uncertainty, even if that resolution is inaccurate. The antidote to this isn't just better data, it's better delivery. Transparent communication is more than just telling the truth. It's structuring the message in a way that respects how the brain works. For example, instead of saying, "The vaccine is safe," which is an absolute statement that invites scrutiny, a more transparent and biologically compatible approach would be, based on large-scale clinical trials and ongoing safety monitoring, we've found the vaccine to have a very low rate of adverse effects. Like all medical interventions, there are risks, but here's how we're tracking and minimizing them. This activates the listener's anterior cingulate cortex, which is involved in error detection and adaptive learning, helping them weigh risks in context rather than rejecting the message outright. Transparency also engages the mirror neuron system, particularly in areas like the inferior parietal lobule and premotor cortex. When a communicator demonstrates vulnerability, empathy, or openness, these neurons fire in the listener's brain as if they were experiencing the same state. This facilitates empathic resonance, which is a foundation for trust, and trust is not just a feeling, it's a neurochemical state. Repeated, transparent communication fosters the release of oxytocin, which increases feelings of connection and safety, and dopamine, which reinforces the memory of positive interactions. There's also an important timing element in communication. When people receive updates in a consistent cadence, whether weekly, monthly, or tied to specific events, they become neurologically conditioned to anticipate information. This anticipation involves the dopaminergic system, particularly the ventral tegmental area, VTA, and nucleus accumbens, which are responsible for reward prediction. When the message arrives predictably and fulfills expectations, it reinforces trust and motivates continued engagement. But when updates are sporadic, reactive, or contradictory, this reward circuit becomes destabilized. The listener begins to doubt not only the content but the messenger. Transparency is also crucial during moments of scientific evolution, when recommendations change based on new data. Many people interpret such changes as flopping, but in reality, this is how science is supposed to work. The challenge is that the limbic system, especially the amygdala, interprets change as instability, which is threatening. To buffer this, communicators must proactively explain why recommendations change, emphasizing that adapting to new evidence is a sign of strength, not confusion. For instance, earlier in the pandemic, we didn't recommend masks because data on asymptomatic spread was limited. Now that we understand the virus behaves differently, we've updated our guidance to reflect that. This type of transparent explanation activates prefrontal cortex regions associated with causal reasoning, which helps integrate the new information more smoothly. From a behavioral neuroscience standpoint, transparency also improves compliance. When people understand why they're being asked to do something, their autonomy is preserved. This engages brain regions like the dorsolateral prefrontal cortex, which governs goal-directed behavior, and the insula, which helps assess internal bodily states. Together, these systems increase the likelihood that someone will not only adopt a behavior but maintain it over time. Autonomy. Supportive messages are more effective than coercive ones because they align with the brain's need for agency. Let's not forget the social context. In group settings, transparent communication has a contagious effect. When one person shares clear, accurate, and open information, others are more likely to mirror that behavior thanks to social learning circuits in the orbitofrontal cortex and superior temporal sulcus. This is why public health messaging should not only come from centralized institutions, but also from trusted figures within communities. Peer-to-peer transparency reinforces norms more effectively than top-down directives alone. Of course, all of this depends on one foundational principle: honesty without oversimplification. The temptation in public communication is to reduce complex science into catchy sound bites, but this often leads to distortion, which undermines transparency. The brain is more capable of handling nuance than we give it credit for, provided it's explained well. When communicators say, "This is a complicated issue, but here's what we know right now, and here's what we're still investigating," it activates the parietal lobes, which are responsible for integrating sensory information and abstract reasoning. People don't need oversimplification. They need clarity wrapped in honesty. In educational neuroscience, we talk about the zone of proximal development, the space between what someone currently understands and what they can learn with appropriate guidance. Transparent communication sits right in this zone. It neither overwhelms the brain with jargon nor insults it with condescension. It respects the listener's intelligence while guiding them toward deeper understanding. And that's not just good pedagogy, it's good public health. To close this loop, we should emphasize that the long-term goal of transparent communication is to build epistemic trust, a psychological state where people are willing to consider information as relevant and useful. This is different from blind trust or obedience. Epistemic trust is built when the brain perceives the communicator as having benevolent intent, relevant expertise, and a commitment to the listener's well-being. It's encoded not just in language, but in tone, timing, and context. And once established, epistemic trust creates neural openness, a brain state characterized by low threat sensitivity, high working memory, and readiness to update beliefs. In that state, science can flourish, behavior can change, and public health can do what it was always meant to do. not simply prevent disease, but empower people to make informed, confident, biologically aligned decisions for their lives and communities. Public health policy often assumes that giving people the right information will automatically lead to the right behaviors. But decades of research in neuroscience and behavioral science have shown that information is only one piece of the puzzle. Human behavior, especially health-related behavior, is not governed by rationality alone. It's governed by a dynamic interplay of emotion, cognition, habits, and social context, all underpinned by specific brain circuits. If we truly want to design effective public health policies, we need to understand the neurobiological systems that drive decision making, motivation, habit formation, and social influence. Let's start with decision making. Every decision, from whether to wash hands to whether to get vaccinated, begins in the prefrontal cortex, the brain's executive center. More specifically, the dorsolateral prefrontal cortex is responsible for weighing options, predicting outcomes, and integrating data from the body and environment. But this system doesn't work in isolation. It is constantly influenced by the limbic system, which includes the amygdala and insula, regions that process emotional relevance, bodily states, and risk perception. This is why simply telling someone that a behavior is good for them often fails. If the behavior doesn't create an immediate sense of emotional relevance, or if it clashes with social norms, the brain discounts it. For a message or policy to motivate real change, it must activate both cognitive and emotional networks simultaneously. That means designing interventions that are not just scientifically valid, but emotionally resonant and psychologically motivating. One of the key insights from behavioral neuroscience is the role of reward prediction and reinforcement. The brain's dopaminergic system, especially circuits originating in the ventral tegmental area (VTA) and projecting to the nucleus accumbens and prefrontal cortex, governs our response to rewards. Behaviors that produce even small positive outcomes like feeling better, being praised, or experiencing a sense of control trigger dopamine release, reinforcing those actions and increasing likelihood they'll be repeated. Public health policies must account for this. If a healthy behavior like getting a screening test, wearing a mask, or taking medication doesn't produce immediate or tangible benefits, the reward system may not reinforce it. In fact, if the behavior is inconvenient, uncomfortable, or socially stigmatized, the brain may actively associate it with negative reinforcement. That means public health interventions need to either build an immediate positive feedback or clearly tie current actions to future, meaningful rewards. This is where behavioral incentives, social reinforcement, or digital feedback tools can play a powerful role. We also have to understand the importance of habits. Much of our daily behavior is not the result of conscious decision making, but rather automatic routines governed by the basal ganglia, especially the dorsal striatum. Once a behavior is repeated in the same context enough times, it becomes neurologically chunked and triggered by cues rather than intentions. This is why telling someone to just make better choices rarely works, unless their environment supports the development of better habits. Effective policy must therefore focus on structural changes that reshape the cues and contexts people experience. For example, placing hand sanitizer at eye level in building entrances creates a strong contextual cue that promotes automatic use. Designing urban spaces to encourage walking, or making healthier foods more accessible and visible, leverages the brain's reliance on cues to automate behavior. These are not just design tricks, they are direct interventions on the neural architecture of habit formation. Another crucial piece of the puzzle is temporal discounting, the tendency for the brain to devalue rewards that are distant in time. This is mediated by interactions between the prefrontal cortex and limbic structures like the ventral striatum. In fMRI studies, we see that people are more likely to make healthy choices when rewards are immediate, but when benefits are delayed, emotional impulses often override logical reasoning. That's why behaviors like smoking, overeating, or skipping exercise persist despite known long-term risks. Public health policy must account for this by reframing time. Messaging that brings future consequences into the present, such as showing graphic images of lung damage or real stories of people impacted by poor health choices, can activate emotional regions and override the natural discounting bias. Similarly, using short-term incentives like rewards for attending checkups or reminders of immediate benefits, "You'll sleep better tonight," taps into systems that govern present-focused motivation. We must also consider self-efficacy, the belief in one's ability to take action and succeed. This belief is grounded in the ventromedial prefrontal cortex, which helps assess personal agency. When people perceive a health behavior as too difficult, complex, or likely to fail, this region shows reduced activation and motivation plummets. That's why public health campaigns must simplify action steps, use language that promotes empowerment, and provide scaffolding like reminders, coaching, or digital tracking tools. Closely related is the role of social norms. Human beings are deeply influenced by what others do, a behavior rooted in mirror neuron systems and social valuation networks involving the medial prefrontal cortex and superior temporal sulcus. If people see their peers adopting healthy behaviors such as quitting smoking, getting vaccinated, or attending mental health checkups, they are far more likely to do so themselves, even if they have personal doubts. This means public health efforts should highlight collective behaviors, celebrate compliance publicly, and use trusted messengers from within communities. One of the most powerful tools in this domain is behavioral modeling, seeing someone like you succeed at a health behavior. From a neural standpoint, this engages vicarious learning circuits that simulate the observed behavior internally, building confidence and reducing uncertainty. Public health messaging should therefore include real people from diverse backgrounds demonstrating success, not just experts explaining why something matters. Importantly, behavioral science also emphasizes the role of friction, the small barriers that prevent action. Even tiny inconveniences like a long form, unclear instructions, or lack of transportation can significantly reduce follow-through. These barriers activate conflict detection circuits like the anterior cingulate cortex, which flags effort-reward imbalances and can inhibit action when perceived effort outweighs expected benefit. Effective policy design must reduce friction points wherever possible. That means streamlining services, simplifying processes, and reducing the cognitive load of health-related decisions. Let's also address stress, which plays a dual role in behavior. Chronic stress, mediated by the hypothalamic pituitary adrenal HPA axis, can impair the functioning of the prefrontal cortex, reducing self-control, working memory, and long-term planning. This shifts behavior control toward the habitual and emotional centers of the brain, making people more reactive, impulsive, and risk-averse. During pandemics, economic downturns, or social unrest, these stress-induced shifts must be considered in policy. It's not that people are ignoring public health guidance, it's that their brains are operating in survival mode. Offering mental health support, financial stability, and stress reduction resources is not ancillary to public health. It's foundational. Let's not forget the importance of identity and moral framing in health behavior. The brain encodes health-related choices not just as practical decisions, but as reflections of personal values. The posterior cingulate cortex and medial prefrontal cortex, both part of the brain's default mode network, activate when we evaluate whether something fits with our self-concept. Public health messages that conflict with someone's identity, whether cultural, political, or moral, are often rejected, not because of poor reasoning, but because of self-protection. Policies must be culturally sensitive, morally aligned, and identity supportive if they are to succeed in diverse populations. Finally, let's examine the power of feedback loops. For behavior to persist, the brain must receive signals that the action was effective. This is governed by closed-loop feedback systems involving the cerebellum, prefrontal cortex, and limbic regions. When people don't see or feel the impact of their actions like wearing a mask or washing hands, it creates an open loop condition that weakens motivation. Feedback mechanisms, such as dashboards showing local case reductions or real-time responses from digital health tools, help close the loop, reinforcing the idea that personal behavior has collective impact. To synthesize this, the brain is not built for long-term rational analysis under conditions of stress and ambiguity. It's built for adaptive energy, efficient decision-making driven by emotion, habit, social learning, and environmental cues. Public health policy that ignores this reality will struggle. But policy that integrates it through strategic design, emotionally attuned messaging, community-based reinforcement, and biologically informed feedback has the power to reshape behavior at scale. We must move away from the idea that knowledge alone is enough. If people don't act on information, it's not always because they don't care or understand. More often, it's because the policy wasn't designed to match the way their brain actually works. Behavioral science, when integrated with neuroscience, gives us a roadmap to fix that mismatch. And when that alignment occurs, public health becomes not just about controlling disease, but about empowering individuals and communities to thrive long-term with agency, dignity, and trust.